Okay, we'll just let everybody give them a chance to log in. Good afternoon. Thank you for joining us for Astardi Medical's webinar presented by Dr. Jae Kim on gaps in standardizing nutrition in the NICU. I'm Tammy Jansen, co-founder and CFO of Astardi Medical. For those of you who don't know us, Astardi Medical is a precision nutrition company providing digital solutions to support nutrition and feeding practices for preterm infants in the NICU. We've been hosting a series of educational webinars, all focused on the growth and development of preterm infants and the importance of feeding, nutrition, and gut health. This is a look at our past webinars. You can view any of them on demand by visiting our website at astardimedical.com. I'm excited to share our incredible lineup of upcoming speakers with you. You can also find the details for these upcoming webinars on our website. Please mark your calendars and join us for our next webinar on April 15th for a presentation by Dr. Bill Hay on neonatal hyperglycemia, perhaps not a benign disorder. Dr. Hay is retired professor of pediatrics and neonatology at the University of Colorado. In addition to practicing neonatology over his career, Dr. Hay conducted a wide variety of research projects focused on maternal nutrition, placental nutrient transport, fetal physiology, and fetal and neonatal nutrition and metabolism. A major emphasis of his clinical research focused on intravenous nutrition in the preterm infant and how to optimize nutrition to prevent postnatal growth faltering. Dr. Hay also is recognized nationally and internationally for his expertise in disorders of glucose metabolism in neonates, including both hyper and hypoglycemia. Watch for the invitation to Dr. Hay's webinar in your inbox later this week. I'm now pleased to introduce our esteemed presenter and expert in the field of neonatal feeding and nutrition, Dr. Jae Kim. Dr. Kim is the Division Director of Neonatology in the Perinatal Institute at Cincinnati Children's Hospital Medical Center and a professor of pediatrics at the University of Cincinnati. His special areas of clinical and research discovery include neonatal nutrition, neonatal bowel injury, point-of-care ultrasound, resuscitation, and the microbiome. He oversees neonatal clinical and translational research with a core clinical research team at Cincinnati Children's. He led the nationally recognized premature infant nutrition program called SPIN, supporting premature infant nutrition, and helped found the UC Health Mother's Milk Bank in San Diego. He is an active member of the American Academy of Pediatrics Committee on Nutrition. He is co-author of The Best Medicine, Human Milk in the NICU, and was a nutrition and growth expert for the California Perinatal Quality Care Collaborative Grow Baby Grow. We'll have time for Q&A at the end of Dr. Kim's presentation. Please post your questions at any time throughout the presentation in the chat box on the right side of your screen. I'll now turn it over to you, Dr. Kim.
All right, great. Had a little glitch there. Hopefully you can see my slides. And I want to thank Astardi and Tammy for obviously inviting me and presenting. I've got a fair amount of content that I'd really like to get through in the next 45 minutes and then open up for questions at the end. Really trying to address the significant progress, but also presence of gaps in how we're standardizing nutrition in the NICU. These are my disclosures. And I wanted to, in 2007, we in San Diego had sort of started the beginnings of developing a quality program around preterm infant nutrition, and really focused on the combination of human milk nutrition and lactation, and bringing those two communities together. And so a lot of what I'm going to talk about are going to highlight some of these principles that we learned over more than a decade of kind of development at University of California. And then more recently, I've been involved as an expert panelist in the Grow Babies Grow Collaborative, which was a very successful project that is completed, is sort of at the end stage completed and in sustained mode. And there's also some observations from this that I'd like to share throughout this. All right, so the stage that's set is one that we have continued to target the growth of our preterm infants like we would had they been in utero. And we know that that's a daunting task because the placenta provides such rich nutrients to our fetuses. And when they come out, we do our best to match some of it. And obviously we can't be perfect about it, particularly with regards to composition. And one of the challenges we see more now than ever is that as our babies get smaller and smaller and younger, we are dealing with huge challenges in the developmental milestones. So although structure and organogenesis occurs early, we actually see significant challenges in trying to make the gut work because a lot of those milestones haven't begun or are in the process of development. And so in the past, there was a lot of fear about feeding preterm babies, and we actually realized that that may not actually be the best way. And in addition to that, there are a number of practices that are now outdated, certainly the heavy use of preterm infant formula, significant amount of medications, significant amount of antibiotic use, and a whole bunch of other drugs that were used that we thought would benefit the gut. And coupled with that was just the multitude of abnormalities and morbidities that we face when we deal with the small preterm infant, but even more so the extremely preterm infant. So when we look at standardization of nutrition, there's a lot of noise. There's a lot of variation in practice. And so the question is, why is that the case? And just like everywhere else in medicine, when we don't have a significant amount of evidence, when the evidence is small, when the evidence is not the highest level caliber, then what we end up seeing is spray in practice and increase in variation. So the principle of standardizing in the face of not enough evidence, but lots of variation really holds well for nutrition. So the concept is really to try to get rid of outliers, to narrow the field so that we don't have such variation, and particularly when we're thinking about how the metabolism of the preterm infant and how the gut of the preterm infant tolerates high variation in delivery of nutrients. This is paramount then that we try to incorporate this. The reasons why we sometimes don't relate to some resistance to following a cookbook, following a sort of set order, fear that as a practitioner or a provider, you may be obsolete, losing some of that control, and losing some of that decision making. But there are a lot of elements in delivering the best nutrition, and each of these elements need to really be standardized. And it's very hard to do that if individuals have their way. And the reason why the problem is so significant for the preterm infant, and even particularly the extremely preterm infant, is the urgency of the nutritional crisis. In other words, in the past, when there was more variation even than now, we under-targeted, under-approached, and had a lot of variation such that virtually every infant in the very low birth weight category were failing to thrive and losing significant percentiles and being undergrown at the time of discharge. And to kind of give you relative terms, I still use this slide, even though it's made many years ago, taking our smallest babies and looking at the relative growth rates of these infants, we can identify that they are growing in relative terms extremely fast. An average adult would have to gain 3 pounds of weight per day in order to match that kind of growth. So recognizing the sensitivity then of that kind of rapid growth makes it really, really challenging. So it's a little frustrating then when we look at the different parts of the nutritional journey of the preterm infant, all the way from the parenteral delivery phase to the time of discharge. And this was something that we did as an exercise as part of the collaborative in California. There are only a couple of areas where there's highlights of really good, strong standardization. So the parenteral area and the early enteral advancement area are well-trodden, well exercised as far as areas for real positive standardization tools for people to use. The other areas where they're growing and tolerating enteral feed, and then finally getting into oral feeding progression, and ultimately some level of breastfeeding, and even nutritional discharge, are poorly mapped, poorly standardized across the way. And it turns out that with the collaborative, the vast majority of teams gravitated to those areas where they identified were needs in their units, but was all in the more highly trodden and highly developed standardization areas in the parenteral and the enteral advancement zones. We do know that in past surveys that there's movement towards more and more standardization. This is outdated now, but you can see in the past, we can identify that in some cases, practices, when it used to be only giving sugar water was the practice, that there was an increase in the amount of protein delivery, for instance, and the use of stock solutions, and addition of different elements to really standardize early nutrition practice. So we know that there's overall trends heading in the right direction. One of the challenges that I see, and it came in my own practice and also in observing other groups, is that a lot of the emphasis that we talk about when we talk about growth happens on the intake side with much less emphasis on the expenditure side. And we know that to grow, you have to have the right amount in and matched with the right amount out, and particularly with respect to energy expenditure. So energy is typically fairly stable, even in the very preterm baby, in the first few days of life in terms of resting energy expenditure. So it's usually not that difficult to manage. But as an infant gets older, there are multiple conditions that really feed into the challenge of having excess energy expenditure. And these include respiratory conditions, tachypnea for other reasons, neonatal opioid withdrawal syndrome that we'll see, or fever. And the other conditions that are important to think about in terms of growth impairment includes corticosteroids and multitude of sort of inflammatory conditions, sepsis being one big one, but we have BPD, we have necrotizing enterocolitis, and we have a lot of post-surgical kids that are also experiencing inflammation that can drag on and affect their overall growth. And then finally, genetic reasons for this. So standardize, as I mentioned before, standardizing the early part, the parenteral nutrition part, I think has moved along very nicely. There's lots of detail that help support practical implementation of delivering high amounts of amino acids early. The question of how early lipids are introduced is still not proven, but most people are able to establish lipids within the first 24 hours and then increments thereafter over the next couple of days. And with some challenges with the micronutrient and vitamin with shortages, we've managed to also deal with that in a more consistent manner. The one area that a lot of people forget about and don't map as much, I think your dietitians or the dietitians in the audience might do this better, is really take a look at the trough or the gap between the parenteral and the enteral period. There's a lot of risk here where how you deliver parenteral nutrition and wean that might actually be leading to a long period, not only of potential water, potential energy, vitamins, minerals, and protein troughs that occur that really end up adding to the overall growth impairment of the infant. And of course, that's also in parallel to how quickly your enteral feeding advancement needs to be to compete. So Jackie Keller in my old institution had put some of these slides together to just show the kind of mapping that's required when you're going from parenteral to enteral nutrition, to map that well, item by item, ingredient by ingredient, to really see, are you able to make that transition smoothly without too many complications. And one of the areas, depending on how you write your TPN and who writes your TPN, how the bags come, you may have significant challenges in making that crossover. So it really is an important detail-oriented process evaluation to ensure that period is optimizing, maximizing the amount of nutrient delivery as you switch over. Remembering that when you start enteral feeds, usually you're starting at fairly low calorie density, and so that changeover that adds to the weakness of that crossover. When we move into the enteral advancement phase, I think, as I mentioned before, this is an area that we're all now much more comfortable dealing with in terms of what to start with, how to advance, protocols that have been put out there. To some extent, some of these other details, like how to define feeding intolerance and when to start, when to stop, may not be as well crafted, and I'd encourage that those areas to be further developed if they're not. And then how to fortify and when you fortify is also something that has been dialed up and down depending on units. In our collaborative, we made a big effort to try to get at least to the halfway point of fortification, so halfway through time to full feeds, and getting infants fortified to the 24 kcal per ounce. And that was a direct effort for a number of the groups to get there, and the overall performance of the groups was really strong for that particular intervention because of the fact that I think people are already using fortifiers and it was just a matter of timing. So I think there's really strong performance in this enteral advancement. One area that I think is probably nuanced, but at the same time maybe something that needs to be delved in deeper in your own unit, is looking at the overall volume. How much water is a baby getting? How much volume of feeding is an infant getting? Because sometimes what you write as an order isn't what actually is delivered, and that there can be some huge discrepancies depending on your system. The other challenge is that when you're doing a mil per kilo per or kilocal per kilo or mil per kilo delivery, if you're changing or measuring weight on a less frequent than daily basis, then you're going to be having gaps in and sort of weaning of the amount that you're delivering because of the fact you're not having frequent weights as part of your measuring, correcting the mils per kilo per day on a daily basis. That's one of the things that might be a repetitive gap that occurs. And then when oral feeding progression happens, certainly that can be a very drawn out time, and it's often difficult to measure some of the feeding loss that occurs in that period. So again, related to volume, that's important. And at the tail end of oral feeding, many of us have witnessed an infant who's feeding what we think is an appropriate 150 or 160 mils per kilo per day, and then we stop their fixed feeding and go to ad lib feeding, and they hit over 200 because their actual drive, the satiety, is much higher than what we think their body is requiring or needing. And if you look across the ocean, you'll see that what we believe is an ideal TFI for preterm babies can be very different in the by even as much as 50 mils per kilo per day different from practices in other countries. So just to challenge you that volume is not a magic imprint in our bodies that say 150 or 160 mils per kilo per day is what's the magic number, and to think about using volume as one of the sliding scales for different scenarios. The balancing act that we face then is trying to deal with the competition of trying to be aggressive on the one hand, coming off parenteral nutrition, getting feeds up, adding all the ingredients so that calories and nutrient density gets to the place we want it to, while preventing significant feeding tolerance and diseases like neck from occurring. The downside of going too slow, on the other hand, is that you end up with significant growth issues, which was really the crisis that we faced many, many years ago, where pretty much every preterm baby was growing poorly. I think it's compelling to see how oral colostrum care has swept into our practice, even though the amount of evidence that's out there is relatively low. So this can be considered an early feeding or an early inoculation of human milk to babies, because a lot of these elements have ability to absorb early in the GI tract. And so maybe it really is both, that we're delivering both a little bit of nutrition and a little bit of bioactive agents that lead to sort of protecting the baby from the get-go. But this is, I'd say it's probably more than 50% in most groups that have adopted this wholeheartedly across units. So it's a fascinating practice change that has occurred. Because some practices take forever to try to make a change, and this one seemed to have moved quickly. And then enteral feeding advancement protocols, we know with retrospective data that they seem to be positive for reducing necrotizing enterocolitis, and that was the evidence before on this forest plot. And so many of us have used that as the momentum, the impetus to get to standardizing feeding and developing automated ways to get the feeding algorithm working. And I think a lot of attention needs to be put here, because a lot of places have used feeding algorithms and failed, or have had very little, as much lower performance and uptake. And details like how this is built into the system, whether it is built within the electronic medical record, if it's automated, if it's done in a way that's actually doesn't depend on the provider, to be honest. And that's one of the tricks that we used early on, to use bedside nursing as a driver to make this happen. Really building in reliability or high reliability ways to get the feeding algorithm to work and to move steadily according to the plan. And a really good feeding algorithm, and something you should measure, is to ensure that the algorithm's being used in most of the cases, even if you have rules to come off it and come back on, that still would be considered compliance to the practice of using the algorithm. And I think that's important. Then a lot of questions is still go up in the air, and I think it's less important in my mind that you nail down the perfect numbers to this in terms of how quickly you increase feeds, how much trophic feeding you have, how early you start, and also some of the ways you deliver the feeding. You'll see a lot of variation in practice. I think what's more important is that you have it down on paper and that is clear. The SIF trial, of this Dorling trial that was comparing two feeding rates, I think is a very important study to review. It showed no difference between two groups of preterm infants that fed at two different rates, 30 mils per kilo per day versus 18 mils per kilo per day, either with long-term neurodevelopment or NEC or sepsis in the short term. And this is reassuring, I think, overall, because of the fact that there were no differences, and people had a lot of concerns about rates even above 20 or 25 mils per kilo. What's less certain, I think, could be does this apply all across the preterm spectrum down to the smallest babies? And so that could be more challenging to answer. So as I mentioned, most of the energy for standardization occurred at the beginning. And then we've got really the majority of the stay of a preterm baby from the time they advance to full feeds all the way to the point of discharge. And I think that's where a lot more emphasis needs to take place and more detail, because of the fact there's a lot of contributing factors that can lead to variation in practice. So if we start right after you've reached full advancement, what happens at that stage? And we can see that there's a lot of variation in how people practice, whether they increase volume a little bit more than their existing protocol. Many will just bump up through calories and by various means of fortifying additionally, whether it's additional fortification that they currently got to 24, or they add other agents, and those other agents have different properties. So if you add formula, whole formula, whether it's concentrate or powder, that's going to add a different mixture versus these other agents like specific hydrolyzed proteins or protein elements or isolated lipid substitutes that go in to add to the feeding. And none of us measure osmolality or osmolarity, and as such, then we may be increasing to ranges that are starting to get pretty high. Most of the time with fortifiers, you're in the 400 range, and with the further addition beyond that, you're probably getting, in some cases, especially over time, well over 500. And add in vitamins and other components in the feed, and you might really be getting into territory where we have evidence of having potential harm to the gut. So that area of how individuals fortify, it really needs to be mapped out well and have good justification, even in the face of not having great evidence for what to do with that. The other aspect that I think is important that I see challenging is defining when a baby in that growing phase, after they've advanced their feed, starts to falter a little bit. What do we do in that case? How do we define the response to that baby who's not growing so well? And in many cases, people have a number in their head. I need to get 18 grams of per kilo or 15 grams per kilo per day increase to be able to attain good weight gain. And often we are not always calibrating the amount of weight loss or the cumulative loss that occurred. So it's the deficit that occurred up to the point where the response is going to take place. And so what I mean by that is just having a number or having a sort of a general approach may be able to get you to attain maintenance growth. But if that infant has lost significantly and had cumulative loss, maintaining that growth is not going to allow you to have that catch up. And so there needs to be a response that deals with the catch up. How do you build that into that? The other aspect that I think is important to separate out, and it goes back to that nutritional crisis that I mentioned at the start, and that is that there are two different approaches to the problem. When poor growth occurs, you either wait for the poor growth to be visible, and that may not be visible right away, there may be a lag time, a few days, maybe even a week, and then a response takes place. And that response could be effective and corrective. The other way of dealing with is a proactive approach, and that's one where you anticipate that this child is going to have more than normal poor growth, and you're going to dial in additional calories, additional protein, additional nutrients to be able to react to that. So what's the difference between the two scenarios? I think the difference in a slow system, a slow changing system, is probably not that bad. But in a system where every day it matters in terms of the growth rate and the sort of the urgency in terms of how quickly the growth is occurring. Remember the 3 pounds per day of relative growth that the preterm baby has at the extreme end. Being reactive then leads to kind of a staircase effect of cumulative loss. And it's really evident when we look at some older studies that by Embleton et al. That was able to calculate not only daily cumulative deficit, but then over time, weekly deficits of, in this case, energy and protein, but you can do the same calculation for other ingredients in the feeding. And so that the concept of trying to be more proactive is very relevant to how you structure your program. And then another challenge is when we go to growth charts is to how do we interpret the growth chart, and how easy is it for you to determine whether an infant's actually falling off. And one of the best ways to represent growth is through Z-score, which is a mathematic way of looking at separation and distance from the mean. And this allows you to represent any of the data points. If we just use percentiles, however, we're going to be stymied by those kids that fall off the percentile chart altogether. So, and we see this from time to time where they're below the chart. And so it's very difficult to know if that baby has gained appropriately at the right trajectory, right growth velocity without a Z-score map. Using Z-score, however, every baby is mapped by a Z number because it's just measuring the distance from the mean. And also, when you represent it in 2 dimensions instead of a curvilinear graph, you're able to see exactly what that baby is doing over time. So, for example, in this case, you see a baby who started off a little bit below the middle of the pack, and then lost some overall Z-score because of return to birth weight. And this happens to every baby who returns to birth weight. There's a fall off in Z-score. And then they recover, and in this case, that infant does not recover fully, recovers partially. And in this sort of setting, with this representation, you're able to see very clearly when a baby is not at the original Z-score, and also if that baby is stable, which would be represented by a horizontal line, or if the baby is catching up with a positive slope or the opposite. So it's a much better representation of growth. The downside is that we don't have tools right now that represent this easily in our electronic system, and it's difficult to map this if you're going to be doing this manually. So I think we need more tools to be able to see it, because I think it'll be more obvious for individuals to represent growth in this way. And there's other areas besides the very low birth weight infant. We put so much emphasis in preterm nutrition on VLBWs, so we kind of left the moderate preterm and the late preterm out in the snow. And I think we need to put more emphasis, not only because they're a large group, but they too have consequences when they don't grow well. It may be not to the same scale, but definitely important. And then identifying which subgroup from these groups are at higher risk of having either complications with feeding or having growth issues need to be also identified and stratified in how you approach them. And most groups aren't having separate feeding algorithms or strategies for these other groups that we know already have deficiencies. Either they have high energy expenditure because of their breeding, for instance, such as in BPD, or they're constitutionally small, such as in the growth restricted infants. And one of the ways that through quality practice is in terms of building in better and much more sustainable systems is to look at high reliability aspects of your system. So what I mean by that are building in things that make it more certain that the practice is going to take place. And probably one of the most powerful ways, if I had my choice, I'd have a static ratio of dietitian to number of beds in a particular unit across the board. And that unfortunately isn't the case across the country. And the reason why that is the case is because that professional is dedicated and reliable to monitor individual patients for nutrient delivery. And we've certainly found that that's a great high reliability way of developing solid delivery of protocols or guidelines and ensuring that infants get the right delivery at the right time. The other aspect that one can build in is something that we worked on in the collaborative, and that is these weekly rounds, or we call them timeouts, where focus and attention is on that infant with respect to nutrition, and have a checklist that can identify, have we looked at different aspects of that infant's growth on a weekly basis, and be able to look for compliance to guidelines and to identify any weaknesses and jump on any deficiencies that that child might have. It's a very powerful way to really effectively bring the whole team to shine a light on nutrition for that baby. And I know a lot of units have had some version of that built in, whether it's physical rounding or virtual rounding. I think either way, it's a very positive thing to do. If it's done at the bedside, I think the benefit of that is you can also incorporate parents into that, and I think that's also very favorable. So think about ways that you can build in more reliability. So if we look at other aspects of delivery of nutrition, one of the biggest challenges has been around human milk fortification, largely because we know that human milk varies as a biologic product, and there are many reasons for its variability between moms, within the same mother, etc. So this challenge means that every sample is different. Every pumping is different from our preterm moms. So this variation is a huge headache for how do we deliver nutrient content in the correct dose. And so if we take a look at individual moms that either pool their milk or provide individual samples, you can see each mother is represented by a different color, and you'll see that every mom pumps different calories, different delivery with every sample. So some have advocated for a pooled approach, but most places have not built in structure to allow for that pooling. The other aspect is that milk changes over time, and one of the big changes that we see is around human milk protein. We know that protein is the secret sauce for growth, for linear growth in particular, and brain development as well. And we know that it changes over time. So how to rectify knowledge of the protein content to be able to deliver a consistent amount in a standardized way is still a vexing problem. And it's one of those things that I think will continue to develop. The other aspect is, as we become more human milk centric in the NICU, we own the entire chain of process of that milk, from the time mom pumps it to it being put into various containers and undergoing various processing steps. And as we go through that, we become, we own every part of that chain, and therefore need to pay attention to the potential risks at each of those steps. And then we've also been hit with some concern about the cow's milk protein that is found in a lot of the products that we have given, not just preterm formula, but was fortifiers, and really a movement that's happened over the last decade to push for more and more products that are both less bovine, so hydrolyzed to some extent, or also more liquid to go away from powder. And that has ultimately given us products that give us higher amounts of overall protein, but also hydrolyzed protein at that. And so we've got that in our hands. We know that these fortifiers work great, in particular with respect to compared to previous fortifiers, and we've had pretty much conversion almost wholeheartedly to these newer fortifiers that are liquid based. So I think that's been helpful. We have less evidence on how those products have changed in terms of morbidity, such as necrotizing enterocolitis, if it really has reduced it in any way. That's still to be determined. And then the other aspect, which was mostly a big fail, was could we not just feed moms differently and lacto-engineer the diet so that it would be unique and would cover up the deficiencies that mom would have? And we realized that that's really hard to do. There are certain agents that are in the fat that we can modify that I think we might have some potential, but more work needs to be done in that area. And then there's been some development with FDA-approved devices for milk analysis. So these are point-of-care devices that can give us content. And so there's really the potential now to start the concept of targeted or individualized fortification. But we're stuck because these are not easy strategies, and it's a lot of workflow that changes. And as a result, and also the data that's out there is limited. On top of that, there's some data around even how we take our donor milk and use donor milk and incorporate it and recognize that donor milk, even when it's sort of strategized to be of more consistent and higher content, is still protein limited and may still lead to growth impairment. So we're not clear whether custom fortification or targeted fortification is the way to go. There's a lot of limitations to that. People are doing mostly what I would say is a broad category of adjustable fortification, whether they're using BUN or they're using growth parameters. People are just being more aggressive beyond just the basic fortification approach. We're also recognizing that the quality of the milk changes and it matters. And so there's different grades of the milk depending on how much processing, how much treatment the milk has undergone and how much time has undergone. Because we know that any organic product, if it sits around, it's going to decompose and be subject to some degradation of its components. And in particular, paying attention to the delivery system, because the delivery system is a huge source of loss. Lots of use of donor milk now that is pretty much considered the alternate for mother's own milk, but we know that there are some comparatives, and we know that in the past we thought it was much higher grade. We recognize with all the processing and particularly the heat that the bioactive agents in donor milk don't survive to the same degree. And so we do have to consider it inferior milk to mother's own milk, and because of a number of reasons. And some of the lower nutrient content is something, as I mentioned, needs to be addressed, perhaps not in a reactive basis, but on a proactive basis. Derivatives of human milk are also coming through, and we need to recognize that things, even though they may have an expense, there's definitely evidence to support that you can boost base nutrients by adding human milk derivatives to try and keep and preserve an all human milk diet. Other measures as we go along the spectrum, the nutrition journey, to really push forward for standardization, which there's plenty of evidence around, is use of skin-to-skin care, whether it's important for bonding, but also for early feeding, feeding metrics to get babies to have higher risk, higher chance of being able to breastfeed, and also for psychological benefit. And then getting babies to the breast early in a non-nutritive in order to really get them on board is something that needs to be standardized, and it really isn't in many, many places. So the oral feeding progression is a big area, and we identified this when we were talking about in the collaborative as an opportunity, but really one that most people have not standardized in a way that I think could be taken advantage of. It's a long period of time. Kids are not growing so well in this period. There's a lot of struggle, and it's often a period where you can get babies to accelerate if you have the right program in place. So not only those things that I just mentioned in terms of skin-to-skin, non-nutritive breastfeeding, building in really stable cue-based feeding, infant-driven feeding practices, as well as being able to have attentive professionals feeding them really, really matter. There's some evidence of technology also helping to augment some of the non-nutritive sucking pattern to improve their skills, and potentially at least in a subgroup of preterm infants, accelerate their feeding and potentially get them out of the hospital faster, which is beneficial. Most places do not have a structured algorithm that allows infants to go in a very graded fashion, increasing in oral feeding and also increasing in their ability to ad lib feeds, which I think is something we underestimate from many infants in their capacity to do that, even before they've reached full oral feeding. And this is an example of an algorithm that we developed in San Diego that worked really, really effectively in getting babies to a stable point of full oral feeding. So finally, the last journey is a journey we often forget. And that's because babies get discharged. And that transition from high acuity to low acuity to sending them out of the hospital it's often a period of major transition and loss of critical information for nutrition. So ask yourself, what do you do and how structured is that process? What is actually detailed in that nutrition trajectory at discharge? How much is the growth chart sent? How much are you conveying to the primary care provider, information that's vital to them sustaining that nutrition plan that's established in hospital? And how much does your community follow these kids early so that you can really address some of the nutrition concerns when they go home? Having a post-discharge strategy that's built in not just for milk or formula or breastfeeding recommendations, but also growth targets, vitamins, and mineral support, what to deal with blood work, and et cetera, are really important. So having a documentation that includes a lot of those recommendations and targets is be incredibly supportive for the primary care doctor, who often finds it daunting to receive a small preemie with a huge problem list and a lot of ingredients in their feeding. And many times what we see is that a lot of those things fall off the wayside and disappear. I think it's very encouraging to see many places in the country developing premature infant nutrition clinics that follow these kids within the first few weeks of life to make sure nutrition is managed and breastfeeding is managed in the first few weeks of life. Because I think the first neonatal follow-up visit at 6 months corrected just doesn't cut it. And a primary doctor visit that goes on a monthly or every other month basis also doesn't cut it. So we often see wide variation in practice in terms of what is available for preterm babies at the time of discharge, whether it's human milk-based solutions or formula-based solutions. We've pushed for a long time to have liquid 30 cal available for discharge, and this has been one possible solution to help support breastfeeding because of its liquid concentrated nature, and several companies have been able to provide this on the outpatient side. So I think this has been one benefit to help manage some of the post-discharge fortification approaches. Recognize too that these preterm infants have major problems going home. A lot of them have significant chronic issues as listed here, and many of them end up in feeding clinics with significant aversion. Many get G-tubes later on. Many have a horrible oral version that needs to be managed for the first 5 years of their life. So we are a major contributor to this situation. I think we need to recognize that what we do in-house matters to how their quality of life is outside. So developing a standardized post-discharge approach, I think, is important. And the details are less important than you structuring these in a way that's efficient and it's repetitive, and it's validated by the provider out there receiving that child, knowing that there's a continuity of care with regards to nutrition and lactation. I think the future, though, is bright. There's lots of change that I can anticipate and that we're expecting. More human milk derivatives, lots of changes in the fortifier area, more ability for us to document and benchmark data, whether it's in hospital and at a much more forensic level, and to carry that as an ongoing dashboard of nutrition that will really help us manage babies. And then significant amount of advocacy that's really become our whole improvement in pediatrics that I think is also going to help move the field. And in the human milk diet area, there's just an explosion of companies that are coming out with derivatives of human milk and ways to process milk. So I think we're going to see some real potentials here. I also think that the concept of infant formula being unethical to very low birth weight infants is very real. There's a number of legal cases that are now present on this very issue, which wasn't there before. And when we look at the broad newborn population, we are seeing increase in exposure of human milk and donor milk to populations beyond their original indication, so moderate preterm, late preterm, and even the term population for supporting maternal breastfeeding. And because nutrition has so much effect on a number of morbidities, we really are looking at a long-term trajectory in impacting neurodevelopment and other long-term disease outcomes in our babies. So it's important to recognize that. So I'm going to stop and just highlight that the concept of bringing nutrition, lactation, and really taking a look at growth is as an important tenet to a good preterm infant nutrition program. And despite there being not enough evidence, that doesn't mean that we cannot standardize the field. Encourage everyone to find champions in your own units and to start small. Start with the easiest thing and move up with your team to be able to build up that capacity to do more. And really encourage you to do weekly nutrition timeouts, because we found that to be really a powerful anchor for developing good practices. And then human milk is clearly still the single most powerful intervention to optimize best health outcomes in all our babies. So guide you to the CPQCC site in California. We have a nutrition toolkit that we developed and revised recently that has a lot of good content to help guide the different areas of the nutrition journey. And then just a plug for the Next Society, a parent group that really has supported one of the big consequences around gut, around necrotizing enterocolitis, and it's really moved mountains because of the parent involvement. And Cincinnati Children's is co-sponsoring a conference with the Next Society this coming April. I encourage all of you to join. It's going to be virtual, and I think it's going to be very exciting to bring the community of NEC together in that conference. And I'll end there. And it does take a village to do all the stuff that we have to do for our babies. And I'll entertain some questions.
All right, great presentation, Dr. Kim, thank you. We do have some questions here. So Andrea says, hello, Jay. I was wondering if you'd like to comment on whether our feeding goals are actually valid, in particular the paradigm of aspiring to follow the intrauterine growth trajectory while the infant is in a radically less supportive extrauterine environment. Dr. Modi's research comes to mind here.
Yeah, so I think there's probably both a yes and no answer. I think the yes is that in the past, I would have thought that, especially as our babies got smaller and smaller, that it'd be really hard to meet that goal. Kids are sick, and they often are really, really a big challenge to return to birth weight and they get back. But I've been impressed at the upper margin of preterm babies, and I'm talking even at over 1,000 grams, that a lot of those babies are ultimately able to get back to, if not their birth Z, to their return to birth Z. And so I'm feeling more buoyed in that population that truly we could attain in utero growth trajectory. The really tiny babies, now that we're heading to 22 weeks and 23 weeks, I think they are a very heterogeneous group and they are very challenged. So I suspect that group may not be as easy to get to target, but with other technologies and other strategies, maybe we're jumping too fast to call them off in that goal.
Great. Would you please comment on the use of BUN to adjust protein intake?
Yeah, this is it's now not so new anymore, but it was really the reflection that BUN, certainly after the first few weeks of life, can represent nitrogen, be a sort of poor man's way of measuring nitrogen balance. So infants who are poorly supplied protein will have very low BUNs, typically even single digit, 1, 2, 3, 4. And in those babies, by targeting that low BUN, by giving them more protein, you would raise their BUN, and there was demonstrable adjustment and correction of growth in the studies that had been published on that. So I think it's not a bad target. I know a lot of dietitians use that. as a measure of thinking, oh, I need to add more protein to that baby, whether it's as a module or as a formula powder or formula concentrate.
Our unit uses human milk-based fortifier on the ELBW infants. However, we've noticed extrauterine growth failure even on 30 kcal per ounce with cream. As soon as they are switched out to bovine-based fortifier weeks later, their growth is significantly improved. How do we resolve this dilemma?
Yeah, so it goes back to that. It goes back to two things. One is the variation in the mother's milk itself. So we know that there's variation. So that's one thing, that maybe we are overestimating what mom's milk nutrient content is. The other concern is, even if you measure what's in mom's milk and think that that's what you're delivering, the delivery system and the multiple processing steps can lose those nutrients along the way. So even though you think you have, say, 20 calorie mother's milk, if it goes through a bunch of steps and gets to the baby, you may be deficient to some degree, which is maybe a little different than when you take, open a bottle of formula and deliver. So there's definitely a number of things that can stymie the delivery of appropriate nutrition. So I've seen this very often, where you make that switch exactly as described, and then suddenly the baby starts growing. You can't figure out why. The other aspect too that's important is that when you measure components in human milk, some of the proteins there are sort of digestive resistant initially, especially the bioactive proteins. So some of those resist digestion and don't ultimately end up as digestive nitrogen sources. So we overestimate a little bit on the amount of available nitrogen that's there. Whereas if you give formula, there are no immunoglobulins, for instance, in formula. Everything that's in there is defined as net protein for digestion, for growth. So that's another small nuance that might contribute to the comparison difference.
Okay. Could you also comment on what constitutes catch-up growth in IUGR infants?
Yeah, that's a really good question. So IUGR, for one, and I didn't have time to mention in the talk, we do a very bad job in defining growth at birth. And what I mean by that is we don't really pay attention to how they ended up getting to that point. Sometimes we have fetal growth curve that helps us a little bit. Most of the time, we don't connect the dots. Even though conception happened way back, we don't allow us to understand, how did this IUGR baby become IUGR? So if it was a long-standing IUGR, that baby is constitutionally smaller. And so the growth expectations of that baby are going to be very warped. And we're not going to expect that baby to ultimately become, meet maybe even their genetic potential, because it may be harmful for them to have too much catch-up growth early on. That being said, there are data to suggest that some of those metabolic programming issues that we are concerned about in the post-term period don't seem to play as much a role in the extremely preterm babies. So I think, as a general rule, if you're trying to just get as much catch-up growth and linear growth on preterm babies that are IUGR, I think you're still reasonably safe to get as much as you can, as long as weight doesn't totally exceed length growth, and you're trying to do it in a matched fashion. I think you're better off having reasonably, if not slightly overgrown babies in that category, than to undergrow them and then really disadvantage them with respect to neurodevelopment.
Mm-hmm. What is your experience with human milk fortifiers? Is your team using the cow's milk or human milk-based ones?
So in Cincinnati, we have multiple units. And so some of our units use the bovine-based and the others use the human milk-based. And our experience has been very good. We've had, historically a very low neck rate with implementation of human milk, use donor milk, and feeding algorithms. We did have a blip a couple of years ago that we've now sort of chasing to see what happened, and we've been stabilized. So in the units that are using the human milk-based fortifiers, they are representing very, very low NEC rates.
Great. And we have one more question, and then we're out of time. Can you comment on your preference for early feeding with defrosted very early milk versus freshly pumped milk after 2 to 3 weeks?
Yeah, so I think, well, the earliest feeding, definitely within the colostrum period, that's golden. That needs to be really triaged. After that, I think there's definitely quality differences between fresh pumped milk. If it's really coming from the very minimal steps from pumping to delivery to baby, that's going to be pretty positive. In general, though, fresh pumped versus say a week frozen milk, you're not going to see huge differences. Freezing is not that detrimental to the components as much as heating is, or long shelf times.
Okay, well, great. I want to thank you so much, Jae, for all your great insights. It was a great presentation, and I hope everybody comes back to see us on April 15th to see Dr. Hayes' presentation. So have a great day. Thank you.
Thanks, everyone.